world of brain surgery has changed dramatically over the past generation. Surgeons are able to remove many tumors and other problems from the brain, often using new approaches that have much shorter recovery times and much better long-term outcomes. Many of these surgeries are much less invasive than old methods that saw the need to cut into a patient's skull. Dr. Daniel Kelly and the team at Pacific Neuroscience Institute have pioneered many of these new approaches, and they've published peer-reviewed papers on their work in an effort to spread the word through the field. Dr. Kelly, the director and co-founder of PNI, joins us today to talk about some of these publications and the implications of using these more advanced techniques for people who must undergo brain surgery. Hi, welcome to the Think Neuro podcast from the Pacific Neuroscience Institute. I'm your host, Dan Faust, and I'm joined today by Dr. Daniel Kelly, the co-founder and director of PNI. Hi, Dr. Kelly, welcome.
Hi, Dan. How are you doing?
I'm doing very well. Nice to see you. Thanks for joining us today.
Great to see you.
And so, Dr. Kelly, today I'd like to talk about some papers that you've published, you and your colleagues at PNI have published over the last several years, in which you've gone into some of the innovative methods you've used for keyhole neurosurgeries. And if you wanted to just give us a little introduction to the subject and how these this kind of practice has evolved or began.
Yeah, so, intracranial tumor removal has come a long ways. It's been done now for probably over 100 years. If you go back to trepanation, it may have been done a long time ago with probably a pretty high mortality rate and complication rate. But in the modern era, we've gone from, doing sort of traditional larger craniotomies to now what we like to refer to as keyhole craniotomies, which is really doing things through smaller openings to minimize scalp, muscle, and bone manipulation, and with little or no retraction of the brain or manipulation of the cranial nerves. The idea is really to sort of sneak in and sneak out. And this is something that I've been working on for the last 25, close to 30 years. And it has evolved quite a bit, particularly with the use and the advent of the endoscope, which is a surgical telescope, which allows us to bring the camera into the space we're working in, and therefore allows us to work through much smaller openings, like through the nostrils. So one of probably our most important keyhole approach is literally through the nose, endonasal, endoscopic removal of a whole variety of tumors, mostly pituitary tumors or things in around the pituitary gland, but sort of this midline corridor that you can get to through the nostrils. So not just the pituitary gland, but things above that, tumors that are up under the frontal lobe, and then tumors that might even push on the brainstem. And these are tumors that can cause, vision loss or hormonal issues and a whole variety of symptoms. And so the endoscopic endonasal approach is really great for that. But the other keyhole approaches that we use now often are the supraorbital eyebrow craniotomy, which is literally a little incision through the eyebrow. And that is opposed to doing a much bigger opening like this, which is more traditional, or even what they call a bicoronal opening. And, given my receding hairline, you would have to do if you wanted it to stay behind the hairline, you have to do a big, coronal incision like that, which is still done in a lot of places today. And so for most things in this area, in the sort of forehead area, in the frontal lobes and the temporal lobes, we can use, for example, the supraorbital craniotomy, or another one called the mini pterional, which is a little incision. It's a variation on what's called the pterional craniotomy. The pterion is an area of the cranium, but it's essentially sort of a side incision, sort of above and in front of the ear, and it's a smaller incision. And those two are sort of very complementary approaches, the mini pterional and the eyebrow approach. And then you have the endonasal approach. Then the other keyhole approaches we use sometimes what we call the retromastoid, which is an incision behind the ear, a little incision that's used for removing a whole variety of tumors up against the brainstem or even in the brainstem. And cranial nerves, such as acoustic neuromas and meningiomas. Those are common tumors in those areas. And then we have some what we call gravity-assisted approaches. I mean, all of these in a way are gravity-assisted. We use gravity to help us kind of allow the brain to fall away so that we don't have to retract. But there's some particular tumors that can be sort of close to the midline. And if we put the patient with the tumor side up, the brain on the other side falls away, and it lets us go through a membrane and reach the tumor without retracting the brain. And so again, all of these approaches are used to minimize collateral damage and to sort of sneak in and sneak out. Obviously, the less harm we can do, the less collateral damage, the better. And these keyhole approaches that have evolved because of the endoscope, better refined, low-profile instrumentation, better neuroanesthesia, and just our better understanding of the anatomy and what we can do working through narrow corridors, all of these things have enhanced the outcomes. And in terms of that, meaning still doing great tumor removal rates with fewer neurologic complications, less need for the ICU, and shorter hospital stay, getting patients out of the hospital. With most of our keyhole operations, patients will go home the next day. Almost all of our sort of straightforward pituitary operations, they go home the next day. Most of the straightforward brain tumor operations go home the next day, and many of them don't even spend a night in the ICU. So the admission, the lengths of stay have really gone down with these approaches, I would say.
Oh, that's fantastic. When did the endoscope first start showing up in surgery?
So the endoscope has been around for a long time, for probably 40 years or so, but it really started to be used a lot in the 90s. For pituitary tumor removal. And the first paper was by this Dr. Joe and Dr. Corral. Dr. Corral was with us for a while. He's an ENT, and they really published the first series a long time ago, getting close to 25 years ago, over 25 years ago, on the endoscopic removal of pituitary adenomas.
The two surgeons that Dr. Kelly mentions are true pioneers in the field, and both are still active today. Dr. Hae-Dong Zhou studied medicine in his native South Korea, where he was a faculty member in neurosurgery in 1982. He then came to the U.S., landing at the University of Pittsburgh in 1989. He has since published more than 110 papers, has pioneered many techniques, and is now a professor and chairman of neuroendoscopy and director of the Joe Institute for Minimally Invasive Neurosurgery at Allegheny General Hospital in Pittsburgh. Dr. Ricardo Corral, a native of Puerto Rico, is an otolaryngologist, head and neck surgeon at Ohio State University, where he joined the faculty in 2011. A doctor for more than 35 years, he has published more than 300 papers. In an interview published online, Dr. Corral, who worked at PNI for a while, tells how he began using the endoscope for sinus and other related surgeries, and ultimately realized its usefulness in skull-based surgeries. Around 2005 or 2006, he said, "We started concentrating on the fact that this can be done to a much greater extent." The endoscope offered different angles, different approaches, and different views inside the skull. In the interview, he said he was confident applying the endoscope to neurosurgery because he saw how well it worked in sinus surgeries. In his words, "The most difficult thing was really to convince my neurosurgical colleagues that we could do it." At first, he just showed them how, after a surgery, they could get a better view with the endoscope than they could with the microscope. Then, in the 1990s, he began working with Dr. Joe in Pittsburgh. Dr. Corral said at the beginning, we had the microscope set up just in case we couldn't do it with the endoscope. So we had a backup just in case things didn't go well. After the first 10 or so, we never prepared the microscope again. We knew that we could do this, and from there again, we moved into other places of the skull base.
And then over time, a bunch of people started using the endoscope more, and it evolved and spread out to particular centers. And it eventually replaced the microscope for doing endonasal surgery, for what we call transsphenoidal surgery. The old approach, which I learned and did for many years, is kind of sublabial transsphenoidal, meaning under the lip, sublabial, and then back to the sphenoid sinus. It's still the same approach, but instead of creating a new corridor under the lip, we use both nostrils with the endoscope in one nostril and then instruments in both nostrils. And I think I attribute a lot of the advent of keyhole surgery beyond the nose to, for at least for me and a lot of people, because we learned to work through this narrow corridor of the nasal corridor. So we were very used to working through, narrow apertures because the nose is pretty narrow, and that you could, with the endoscope and these instrumentation, you say, well, we don't need this big scalp incision and this huge, bony removal. We can do this through much smaller openings. And that's how I think it's evolved. So this really started in the late 90s and then really took off over the coming decade. There was a huge explosion of endoscopic endonasal surgery beyond the pituitary gland from, say, 2000 to 2015. There was really a lot of advancements made in reducing complications like spinal fluid leaks. Early on, when they would do these big approaches, the CSF leak rate was very high in some of the papers, 20, 30%, which is just way too high. A lot of those patients would get meningitis, for example, and other complications. And so it really evolved a lot. It was a really rapid evolution of the technique and the technology. I'd say 2000 to 2015, or maybe a little starting, 1998, somewhere in there is where it kind of exploded.
Fantastic. And I'm curious, how big are these tumors that you're able to essentially, I mean, first of all, these scopes are very small. These cameras and the tools are very small to be able to, when we think of fitting through a nostril and working their way into this small, tight space, but also these tiny tumors that can cause such big problems in the brain are able to come out through that same route.
Yeah. Well, so just for reference, the endoscopes that we use are rigid 4 millimeter endoscopes. That's usually the size. So it's a 4 millimeter diameter, and they're high definition. So the views are really amazing. And there's a 0-degree scope, and then there's a 30 and a 45 degree of the three that we typically use. So if you're using the 30-degree scope, but the scope's going straight, you have an angled view off at 30 degrees or 45. If you're using one of the angle, which is really helpful, which is why you don't need this huge opening, because the scope is going to kind of show you around the corner, so to speak. And but the tumor sizes really vary. So for the pituitary tumors, say for Cushing's disease, which is an excess production of ACTH, adrenocorticotropic hormone, that can lead to overproduction of cortisol, which can then lead to hypertension, diabetes, cognitive changes, brittle bones, wound infections, a horrible disease from a little benign tumor. These are often very tiny. They're often so tiny we have to explore the gland. So they can be what we call microadenomas.
Wow.
The bigger pituitary tumors that cause loss of pituitary gland function or vision loss are bigger. They're usually over 2 or 3 centimeters. To lose vision, usually at least 1.5 centimeters. 2.5 centimeters is about an inch. So you can imagine. So and then there's pituitary adenomas that are classified as giant adenomas, and those are 4 centimeters or bigger. So, those are big tumors, and they cause, typically pituitary gland dysfunction and vision loss, headaches, that sort of thing. And we can do all that through the nose. We do, 98% of all pituitary tumors are taken out through the nostrils because of their location. But then going to other tumors, things like meningiomas, which is another common, benign brain tumor, typically benign. We can remove meningiomas through the nose that are as big as 3 centimeters or so. When they get bigger and they spill out lateral up beyond the carotid arteries or beyond the optic nerves, then we need to go from above, or we go from below. We can take a lot out from below, but then we may eventually need to go from above. Going from above, say through the eyebrow, we can take out very large meningiomas or metastatic brain tumors or gliomas, 4, 5, 6 centimeters. Occasionally they're that big. And we can do all that through this little incision through the eyebrow and a little, the craniotomy is literally about that big. So that's
And just
pretty
as a,
standard stuff now for us, for our
yeah.
group.
And just as a side note, that eyebrow has the advantage of being not even visible to other people. The scar is right there behind the eyebrow grows back, and people
Well,
can't
so
even.
yeah, that's an interesting thing. So we never shave the eyebrow. When for most craniotomies, we do a little shave, we do something small and, little, but you don't want to shave the eyebrow because they don't grow back very well.
Oh,
So the
interesting.
incision goes right through the thickness of the eyebrow and literally comes out a little past the end of it typically. They don't all heal perfectly, but they heal pretty darn well. And we have in a bunch of our papers, we have pictures. One of our papers on the eyebrow, we have a montage of patients, and in a number of the patient, you really can't see what you'd have to guess as to what side you went on. But you can, if you look real closely, there's always going to be a little bit of a scar. And sometimes people get a little wasting of the temporal muscle a little bit. But we really do try to do a really nice cosmetic closure. And it's remarkable how well it heals, and people are pretty happy. People are pretty amazed by how they look afterwards. So
Yeah.
we tell them, we warn them, we say when you wake up, sometimes just because of the retraction, their eye may swell shut and bruise like they were I would say you may look like you got in a barroom brawl. That goes away. And they often will have weakness of the forehead. So my eyebrow is wrinkling, that it'll look like they got a Botox injection on that side. And they may be numb up here because the supraorbital nerve comes up here, and we often stretch it or, traumatize it a little bit in the approach. And that almost always gets better as well. And we've looked at all these, numbers and the recovery, and it's a small minority, under 5% of the patients who have, persistent numbness or weak forehead muscle, that sort of thing. So it's pretty good approach from that standpoint.
Well, it's great because it's just also I could tell you're thinking these are people you're operating on, and they're of course everybody's thrilled to get the brain tumor out, but then the next question is, how am I going to look, right? How's this going to affect?
Yeah, I mean, once they get past that, the trauma and the frightening nature of the brain tumor, their vanity comes back, and they want to say, what am I going to look like? Am I going to look like Frankenstein? And so it's a real thing, and we like to, cosmesis is an important concept as well. So not
The
primary, and I would just say one thing is that we, you got to make sure you treat the problem. So we would never do one of these if we didn't think we could take out an adequate amount of tumor. And that's been one of the critiques of keyhole surgery. Well, you guys are just doing these little openings. You're really not taking a lot of the tumor out. You can't see properly, that sort of thing. And that's just not really true in our experience. And I do think it's a matter of experience. My philosophy about aggressiveness of removal is I'd much rather leave a little tumor behind with a patient who's neurologically doing well and gets out of the hospital than, go for broke and try to take all the tumor out and wind up with a patient with a, permanent double vision or vision loss or a stroke. And I think this idea of what we call maximal safe removal is really key. And so that's still the goal. And these, we choose the approach that's going to give us the best shot at a significant removal. So,
Great. Well, I think that's a good segue into these papers because you note in some of these papers that this remains a controversial approach, and I think the wonderful thing you've done here is you've documented, you've kept the data from several hundred surgeries and can show the results. And so I wonder if you wanted to talk about some of these papers and what led you to put that together.
yeah, so we've been writing papers for a long time. I think I have now 160 or so peer-reviewed publications, and over time, these go back to my early career when I was a junior faculty at UCLA, so from the early 90s onward, and we've always tried to publish our results and learn from them, and give an honest assessment of what we're doing, and so um, we've published quite a bit in the last 15, 20 years on these various keyhole approaches, and a lot on pituitary tumors, hormonal outcomes, complication rates, that sort of thing. The 5 papers that I showed you, I guess the one I would start with is the one on pituitary adenomas, and that was really sort of our 10-year experience or so of doing fully endoscopic endonasal removal of pituitary adenoma. So just looking at those and all the different subtypes. And it was really about complication avoidance and some of the techniques that we've used to minimize the risk of loss of sense of smell and taste, um, not injuring the gland, not injuring the carotid artery by using the Doppler probe on every case, and then really minimizing the risks of a spinal fluid leak, a postoperative leak, by having a sort of a set protocol for how we repair the defect we create in the skull base. And basically that studies, I think it's a little over 500 patients. I think the paper came out in 2021 or so. And it, basically showed that we had, very, it came out in 2021, I guess. And, a really low complication rate. We had no carotid artery injuries. We had the major complications of hemorrhage, stroke, spinal fluid leak were all extremely low. And I think it speaks to the teamwork involved, working closely with ENT. My partner, Dr. Chester Griffiths, one of the founders of the group, is a superb endoscopic endonasal surgeon, and we have some other people on the team now. Michael Young, who also does this approach with us. With my partner, Dr. Barkadarian, we do the majority. Dr. Sivakumar down at Little Company of Mary. And so this sort of protocol-driven approach to pituitary adenoma surgery, I think, has really made it very safe and effective, and with very high remission rates, extremely low complication rates. And the vast majority of the people go home the day after surgery. And so I think it speaks of sort of this approach, this team approach, and using these different safety measures, using navigation, which is sort of like a computerized, GPS for where you are, the Doppler probe for localizing the carotid artery. I published a paper on that many years ago, and learning the hard way, injuring a carotid artery in the opening, because the pituitary gland is bracketed by the carotid arteries. So it's always right there. And some of the tumors go out around it or behind it, and you have to know exactly where it is. And you can usually see the kind of the contour of it on the bone, but it's a complication that is dreadful and potentially fatal. And the Doppler is this little probe that you can put right there, and it's real-time navigation, and it can show you exactly where you don't want to cut. Um, And it's, it's a really commonly used technique now, and it's literally a lifesaver and a
You have
brain
to
saver.
have nerves of steel when you're working in that space.
Well, you just get used to, this is the work environment we're in, and you just have to, you know, soldier on. And yeah, but you have to be thinking of all these things. It's about situational awareness. I think when people have, most surgeons, when they have a complication, preventable complication, um, it's because they kind of, you got really focused on something else, and you didn't realize you were wandering closer and closer to the artery, or you didn't use the Doppler. I mean, we use the Doppler probe on every single case. We never open the dura without Dopplering the tissue first. So
And Doppler, this is what we hear about in weather and in other types of science. Is
sort
that
of, yeah, it's a sound, yeah, because the pulsating blood going by the probe makes you turn it into a sound, and you hear this whoosh, 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 and it's, really clear, and it's very accurate and directional. And so it allows you to make a safe and wide opening, that if you don't have that, you may be much more conservative in your removal, or you open too much and you injure it. The carotid's a pretty tough artery. It's a big, thick vessel. But if you put a sharp blade directly into it, you'll have a problem.
yeah?
So anyway, that paper just sort of summarized all of these complication avoidance techniques, and that emphasized the team approach. Um, we wrote a paper years ago called Pituitary Centers of Excellence, and it was about and it was about using all of these colleagues, endocrinology, neuro-ophthalmology, ENT, radiation oncology, pathology. It's the pituitary tumors are complex in all the potential things that they can, cause havoc with. And so it's not uncommon for one of our patients who has a pituitary adenoma, and this is one of the unique things about P&I when they come to see us, is they can see me, the neurosurgeon, the ENT who's going to operate on them. They can see our neuro-ophthalmologist, Dr. Krause, and they can see our endocrinologist, Dr. Tall. And that doesn't happen hardly anywhere else in the country, as far as I know, where they can see the four specialists who are going to be primarily involved in managing their pituitary tumor all in one day, in one visit. And so that's one of the things we love about P&I. It's this sort of patient-centric care under one roof.
What are the ideas you had in founding the
Mhm.
institute?
Yeah, exactly.
Yeah, that's fantastic. Are all four of those surgeons in the operating room, or maybe at different times?
No. Well, Dr. Griffiths is the only surgeon in the operating room with me for those. Dr. Krause is a neuro-ophthalmologist. He does some surgical ophthalmology, but he's not in the room. And the endocrinologist is a medical doctor. She manages the hormonal highs and lows, that sort of thing.
And so, I'm curious as to what kind of reaction you may have gotten when you publish a paper. Do you hear from other doctors? Is
Yeah,
that have an
we
impact?
yeah, we get a lot of, attaboy and way to go. You guys are, doing great work and that sort of thing. Yeah. I mean,
But I think, as I understand, one of the goals that and several of your colleagues have talked about at PNI is to uh, try to raise the bar and see other surgeons around the country or around the world use some of these techniques.
yeah. And you know, being going at this for many years now, 30 plus years, there's a community of people that we see regularly at the meetings, and that we know and that we stay in contact with. And there's some, big centers we're very close with the group at Ohio State, Danny Prevedello and Ricardo Corral, people at UPMC, there, the people at Stanford, a few, and a bunch of others. And in this world, there's a lot of camaraderie, people doing the same thing, and all kind of working to move things forward. We had a very long, close collaboration with the group in Naples under Paolo Capabianca, who is just an amazing neurosurgeon and scholar and good guy. And so it is sort of an international community, I would say, in these areas, and there's a lot of cross fertilization of ideas and lots of good discussions, and people learn from each other and learn from each other at the meetings and sharing these sorts of things. So yeah,
That's great.
that's how the specialty grows.
Dr. Kelly and his colleagues also published a paper in 2021 on using the keyhole approach to removing tuberculum sella meningiomas through the nose or the eyebrows. After years of trying both routes, the team at PNI gained enough experience to share its knowledge with colleagues elsewhere. Here, Dr. Kelly describes those tuberculum sella meningiomas and how they're removed.
These are meningiomas that typically sit on top of the pituitary gland, and as they grow, they typically cause vision loss. They're quite a bit more common in women, as are all meningiomas. They're hormonally driven tumors in many cases with progesterone receptors on them. And over time, as they get bigger, people can lose their vision. They can develop what's called a hemianopsia. They lose their peripheral vision, or they can have tumor that kind of growing out one of the optic canals and can cause vision loss more in one eye than the other. And so we've been, even, 20, 30 years ago, we started removing some of these through the nose, as have others. And we accumulated quite an experience with these. So this paper looks at going essentially, as we like to say, from above or below, through the nose or through the eyebrow. And so comparing these two keyhole approaches and why did we choose one over the other? And it's based on tumor size, the growth pattern, and one of the most important differentiators or directors in terms of which way to go is the tumor invading one of the optic canals, because the tumor can grow out through the two optic canals, and it typically grows on the inside of the nerve, and that's best approached through the nose. So over time, we have removed more and more of the tumors, these tuberculum meningiomas, through the nose as opposed to the eyebrow. So if they have unilateral or bilateral optic canal invasion, we typically will do that from below because it's safer for the nerves, because we can just visualize them better. If it's a much bigger tumor, if it spills out to the side over the nerve, then we may go from above through the eyebrow. But I'd say now it's about 60-40, 60% we go from below, 40% we go from above. And the thing with these kinds of removing a meningioma through the nose versus removing, say, a pituitary tumor is very different in terms of complexity, because essentially you're doing more of a craniotomy through the nose for the meningioma, because you have to open the dura, you have to do a much bigger opening. The risk of a spinal fluid leak is much higher. And so we use, for those, when we reconstruct the sella or the defect in the bone, we not only will typically put some fat there and some collagen and maybe replace some bone, but we use what's called a nasal septal flap. And so this is if you think of your nose sort of as a triangle of tissue, we literally, Dr. Griffiths, the ENT, cuts a triangle of mucosa from one side of the septum with its vascular pedicle intact, and it's elevated and rotated back up to the skull base. And it sticks to the skull base, and it's got its own vascularity. So it's really effective. And that was something that was developed in the early 2000s, not by us, but by others. And it really changed endoscopic skull base surgery because it really reduced the risk of spinal fluid leak and meningitis.
Oh, and you're repairing, essentially, you have to cut through the skull at some point to get to these things.
Yeah.
Yeah.
I mean, even for a pituitary adenoma, in some ways, it's a craniotomy. It's an opening in the bone of the skull, for sure, But it's when you go above and you get into the brain space and you create a defect, say this big, it's or even bigger, you got to seal it up. That's been the big risk. And um, so going from below, the risk of it's better for the nerves in general, based on for the majority of them, but you have to be, adept at repairing the defect that you create. So anyway, that's what that paper showed. But both approaches are good, and it just depends on the shape and size and location, and sometimes how the patient's doing, and sometimes you could flip a coin and you say, well, what do you prefer? Once in a while you can say to the patient, we can do it either way. There's not really an absolute correct way here.
And I gather it's, I mean, you talked about mentioned radiology, but I imagine MRIs or something beforehand is what helps guide your decision making in
Oh
that.
yeah.
Yeah.
No, the MRIs are critical. Yep. They're critical. So that was that paper. The staying in the meningioma realm, and I'm saying this because, so many of the tumors that we operate on, meningiomas, they're the most common primary brain tumor, and they are more common in women. And in certain locations, they're much more common in women. But so,
Do we know why?
well, probably because of this hormonal sensitivity they have. In fact, we've written up a series of women who had their meningiomas diagnosed during pregnancy because they've been known to grow and enlarge during pregnancy. We've had women who came in with vision loss. One woman years ago who didn't even know she was pregnant. She was early in the second trimester of pregnancy, and she was losing vision from a big tuberculum cell meningioma. We had a lady a couple of years ago who was having really bad headaches, couldn't just really uncomfortable, finally got an MRI, had a huge meningioma that was causing a lot of brain swelling. And when they got her into the ER, she was pregnant with twins.
Wow.
And
Without
so
knowing.
Mhm. But
Wow.
she was late in her first trimester. So she was, she's only a few weeks in, but she didn't know. So, and, she obviously had the meningioma before that, it's not like the pregnancy caused the meningioma, but it adds a little fuel to the fire. And it's a well-known potential occurrence. And so it's an interesting thing. And it turns out the best time to operate on a woman with a meningioma during pregnancy is the second trimester, because that's when the risk to the fetus and to the mother are the lowest. And it's beyond the first trimester, the anesthetic risks are pretty high for the fetus. And in the third trimester, the risks are almost a little bit higher to the mom. So we aim for the second trimester if it has to come out, or sometimes we wait. If you can wait till after delivery, that's even better. Sometimes you just can't wait.
In a 2022 paper, Dr. Kelly and his colleagues looked at all the meningiomas they treated over more than a decade. They had used the keyhole approach on the great majority of these cases, most commonly through the eyebrow and the nose. They studied 193 patients to get a sense of how well they performed, things like the complication rates and length of stay. Many of these tricky tumors had complications and couldn't be entirely removed.
35% were through the nose, 34% through the eyebrow, 18% retromastoid, around 10% minitheriomal, and then a couple other approaches. And so, and in many of those cases, we use the endoscope. But obviously for all the endonasal approaches, those were all done endoscopically. And so this was again, just showing this idea of the utility of keyhole surgery. We did make the point for, a lot of the meningiomas that were called invasive meningiomas of the skull base get into these compartments where you simply can't remove them all. It's just impossible to remove them all. They get into this area called the cavernous sinus, which is where the cranial nerves are coming out and exiting the skull. or in an area called Meckel's Cave, and other areas like that where you simply cannot remove them completely without, causing really severe complications to the patient. And um, in those subsets, we had almost none of those were removed completely, and that was sort of the intention. We didn't try to. We remove as much as we can, and I think one of the ways that we conceptualize this is that for a lot of people, these kinds of meningiomas become essentially a chronic disease. They're going to be with them all their life. We take out as much as we can. We watch it. If it's a typical grade 1 meningioma, then if there's no growth, we just continue to image them periodically every 6 months to a year. But if they do grow, then you either have to do radiation, focused radiation, or you can do another surgery in some cases. Unfortunately, for meningiomas, we still don't, we lack any really good sort of chemotherapy, immunotherapy.
No.
Nothing really has been shown to work. A lot of people are looking at that, but we haven't found something that is effective. The two mainstays of treatment are surgery and radiation. Unfortunately, radiation is pretty effective and generally pretty safe as well.
Oh, good. And so when you say you have to leave some, but I presume that would be the case even if you went in the old way.
Yeah, in great majority of cases. I mean, there's some, aggressive skull-based surgeons who will do these very big approaches and try to remove the whole thing or the vast majority of it, and they sometimes succeed, but the downside is the potential complications of cranial nerve injuries and strokes and that sort of thing. And not that you can have a cranial nerve injury and a stroke in our keyhole approaches, which we of course have had, and we document all that, but the rates are pretty low. And so as the surgeon, you have to sort of make the decision, what is the ultimate goal here? And I think more and more neurosurgeons coming to the conclusion that the goal is we want an intact patient with good quality of life. And if we leave a little, of a benign tumor behind, we have other methodologies or modalities to treat them. And so, quality of life has to be sort of the number one priority, I think. Yeah.
The one of the interesting things about these papers, I mean, unlike some other fields of medicine where they can do a double-blind study or a placebo control, you don't have that luxury in neurosurgery. So you can't tell what would be the outcome if we did it another way, which I guess is partly why there may be still some skeptics out there.
Yeah, and I think that's the big problem. I mean, we're not doing randomized double-blind trials, which is sort of the gold standard, and we probably never will. And so it comes down to almost expert opinion, and frankly, that's why a lot of these papers and in these journals, they don't rank very high, because these are essentially case series.
Right.
And we kind of make fun of each other, and we say, this is the way I do it, and here it is, and here's our data. And you try to, in the discussion of the paper, you compare it to outcomes from other publications, but it's not ever apples to apples. It's apples to oranges, and it's using different techniques. So these are the true shortcomings of these papers. It's really, this is how we do it. We have pretty good outcomes, and this is why we think it works. And these are some of the shortcomings, but it's not as rigorous as many in medicine would want it to be. So that's one of the shortcomings of these kinds of endeavors. But I think the bigger point is we're constantly trying to improve what we're doing and make it better for the patients, make it more efficient, get them out of the hospital sooner, and reduce costs, those sorts of things. Those are all important goals. So.
And that's a perfect transition to this latest paper, which talks about your experience during COVID.
Right. Yeah. So that was a really interesting paper. It was funny because in COVID too, we also we had some downtime. There was a lot of things we couldn't do, but we still had to take care of our patients with brain tumors. And so one of the ideas I had was we had already been, trying to get people in and out of the hospital quickly, um, complication avoidance, all these things. But during COVID at our hospital at St. John's Health Center in Santa Monica, there was a real bed crunch in much of 2020, 2021. And also if you came into the hospital, you could potentially get COVID from the patients. And so, but nonetheless, people with brain tumors and pituitary tumors needed their tumors taken out. So what we did was we started doing this even more aggressively than we were. We would tell the patients, okay, we're going to do your surgery. If everything's going well, we're going to probably get you out of the hospital the next day, presuming you're doing well and your MRI looks good and your numbers look good, and that's sort of expectation management. It's an important thing, because if you tell the patient, well, it's going to be a long operation, you're probably going to be in the hospital 2 or 3 days, and you're going to slowly come out of it. But then they go, okay, well, that's how it's going to be. If you say you're going to have your surgery, you're going to wake up from the recovery room, you're going to go to your room. The next morning, we're going to do your MRI, and if that looks good and you're up and around walking, you're going home. You don't want to be in the hospital. All this, you'll be much more comfortable at home. Food will be better, and you don't have to worry about getting COVID or from the patient population. We also informed people in the pre-op and nursing, all the nursing, and we also do anesthesia. The anesthesia technique is such that people wake up quickly. It's called total intravenous anesthesia. So all of these things were sort of added in. And so we looked at a cohort of patients right before the pandemic, both craniotomies and endonasal approaches. And we looked at length of stay and ICU utilization and complications. And what we showed in these two groups, and it was, like 160 in the first group and 130 in the pandemic group, that the length of stay went down pretty dramatically. The median length of stay went down to 1 day, one night in the hospital. And ICU utilization dropped from like 80% down to 25% or something like that for the patients getting a craniotomy. And it just showed that, you sort of get into this mindset where you have to do certain things a certain way and people need to be in the hospital. And it's just not the case. And so this was good for us to push, and, better for the patients. We had no increase in complications. We didn't have any people that came back from home that we'd sent them out too early and they bounced back into the hospital. That wasn't an issue. And I think people were frankly happier about it. And so we've never changed that approach since then. And that was a good way to sort of force our hand to even further ratchet down, the time in the hospital and resource utilization. And of course, the hospital and the administrative team love to see this sort of thing. They love that the patients come in and go out quickly.
Yeah. I'm thinking necessity is the mother of invention, and you had to rise to the occasion. And I can remember that period during COVID where, non-essential surgeries or elective surgeries were, put those off, but like you said, some of these meningiomas and other tumors
They
can't
couldn't.
wait.
Yeah, and we actually put the quote in the paper in the discussion, from Winston Churchill: "Never let a good crisis go to waste." And
Saw that.
he was right. So yeah,
Yeah. The well, I think it's Yes, it's great. And so I imagine that you still try to think of new ways to keep pushing it forward. Do you have any sense of where you can go next?
We do, and I have some my co neurosurgeons, junior faculty. They're always trying to push the envelope too. They're pushing me. I'm becoming kind of an old guy now, and I'm looking to them to continue innovating. We're making incremental improvements. One of our doctors, Tumor, is pushing this idea that's out there a lot in surgery now called ERAS, enhanced recovery after surgery, and that's about sort of again expectation management, using minimally invasive approaches, and also nutritional things. Getting people to eat the right things before their surgery and after their surgery that can make a big difference. And so that's, I think, ERAS protocols, which have been in place for a bunch of things in general surgery and spine surgery and other areas of neurosurgery, are going to help improve that.
And I imagine also the technology is always improving. And
Oh, I mean, I think it's plateaued a little bit. The microscopes we use are great. The endoscopes are really good. There are some 3D endoscopes, which are okay, but they're not much better than the really great HD endoscopes that we have. We have great instrumentation. We have things that sonicate the tumor. We have little ultrasonic aspirators, and they can be on very long, thin shafts, so they can go through the nose or through a little corridor. Um,
talk to
but there's
Dr. Vivian Wu about some of the robotics
Yeah,
techniques.
yeah, and robotics has still not really hit intracranial neurosurgery yet. I think that's still a ways off. Be after I retire, probably.
Well, very good. Thank you so much for your time today. Really enjoyed talking to you and learning about how
Why?
how you've been able to keep moving the needle forward.
Well, thanks, Dan. It's been a pleasure.
All right, Dr. Kelly, take care. Thank you.
You too. Bye-bye.
Listening to Dr. Kelly, one gets a sense of the vast challenges inherent in brain surgery, but also the incredible sense of hope that people have. They don't need to stay in the hospital as long as they used to. They won't have a terrible scar. And best of all, their tumor can come out and they can return to a healthy life. And every time the field advances, that only inspires the doctors to push forward even further, to find ways to get even more of the tumor and make sure their patients can live with the greatest sense of health. Thank you for listening. This is Dan Faust. Tune in next time to the Think Neuro podcast from Pacific Neuroscience Institute.